Hello, and welcome to another Piper Pod. Today we're going to continue with pharmacology, and we're going to look at medications associated with mental health. Now, mental health is a particularly difficult disorder. There's a lot of overlapping symptoms and a lot of disorders that complement one another as well. What I mean by that is it's very common to be given a diagnosis like schizophrenia or bipolar and then have associated anxiety and depression mixed in. So when it comes to pharmacology, you'll note that a lot of the medications will actually overlap as well in their management. Now, mental health can be difficult for people to get their head around, mostly because there's no pathogen, if you will. So there's no virus, bacteria, injury, or anything like that that can be seen or witnessed. And a lot of the times, the most profound signs and symptoms that the patients feel are very personal and internalized. So again, there's no projection or real projection of those feelings. The stigma's getting a little bit better, but it still exists amongst the community and even in the health community. So whilst we go through this, we'll have a look at a few disorders and their complementary medication, but unfortunately we will not have the time to give the real management of mental health justice, which is obviously support, cognitive behaviour therapy and social networking. The main management is associated with mental health disorders, but we're just going to look at the pharmacology today. So before we get stuck into mental health itself, we just need a little bit of a recap on what neurotransmitters are. A lot of mental health disorders have been linked to either high or low levels of certain neurotransmitters. So a neurotransmitter is a chemical signal that's found in the body that is used to pass on the message between the actual neurons themselves. So it's the chemical signaling that's used to pass on the action potential. Now, there's many different types of neurotransmitters. You can see a few common ones on the screen in front of you, and each one of those will react to different receptors, which will follow a different pathway, which obviously has a different response. So the brain is filled with these neurotransmitters and neural pathways, and a lot of the time the relationship between the neurotransmitters is required in order to have certain feelings or have a certain perception of oneself and space. So when there is a disorder that interrupts these neurotransmitters, then you get your associated disorder. So neurotransmitters like dopamine, noradrenaline, serotonin, and even sometimes acetylcholine are heavily associated with mental health disorders. And there's also one called GABA, which plays a pretty strong role in things like anxiety. Let's start and we'll have a look at our schizophrenia. Now, schizophrenia is a mental health disorder associated with extremely high levels of dopamine. Okay, so it's a type of disorder that involves a very overactive brain. Now, dopamine, generally speaking, is used for our pleasure centers or reward centers. But when we have a huge amount of these particular neurotransmitters in the brain, then it ends up having an overdose of messaging. So you end up with disorganized thinking, erratic behavior, and it's often defined as a chronic psychosis. Many people will incorrectly state that people with schizophrenia will have a split personality, but it's not even remotely close to the condition itself. Schizophrenia is associated with delusions of the person's environment, hallucinations, most commonly auditory hallucinations, and just think of it as an extremely overactive brain that the person can't actually coordinate. So if you're having a conversation with someone who suffers from schizophrenia, you'll find that the conversation will go very erratic, you may not understand, and it's very difficult to keep up. It's also heavily associated with things like delusions and paranoia as well. In regards to medication, the main medications used are obviously the ones associated with blocking this dopamine receptor. So there's two main classes of antipsychotic drugs that are used in schizophrenia. We have the typical, which is the first generation, and then we have the atypical, which is second generation antipsychotics. Now the typical medication, or the first generation antipsychotics, had been around since the 1950s. So prior to this, patients with schizophrenia would often just get put in a psychiatric facility and pretty much have no management at all. Now the first generation antipsychotics work by blocking the dopamine 2 receptor. Okay, so the dopamine 2 antagonist. And by blocking this receptor, they reduce the effects of dopamine in the postsynaptic receptors themselves. So the message can't get passed on. That's essentially how they work. Now, unfortunately, the first generations have other effects on different receptors. So they also interact with your muscarinic, your histamine, and sometimes they interact with certain serotonin receptors. They're also associated with high levels of prolactin being released, and therefore can have a lot of side effects. Now the side effects aren't life-threatening, but can be very, very debilitating, which we'll look at soon. Now the groups or the classes of these first generation drugs are broken up into three main classes. So there's your phenothiazine, which most classically is your Ligactyl or your chlorpromazine. So that's a very old style drug, has associated effects with use for migraines, but it is one of these typical antipsychotics. The second drug that fits in this category is your butyrophenones, and there your haloperidol is the main one associated with that class. The third class is thiazanthines. The effects of these drugs can be seen within 1 to 2 days, but sustained improvement usually takes about 2 to 4 weeks. As far as full effects as an antipsychotic, it can take up to several months before you have full control over it. When we look at our second generation antipsychotics, they were designed around the 1990s, the new antipsychotic medication. So they're generally called atypical, and what they do is they actually antagonize serotonin receptors, and they have weaker effect on the dopamine receptors. So they initially took over the first generation as there was a perception that they're safer, superior, but over the years studies have been released that says they're pretty much equivalent as far as effects go. Now, certain medications that fit into this class is your olanzapine, is a classic one because it's used in a lot of mental health disorders, and you also have your risperidone as well. So the problem with second generation one is over the years they've found out that they have greater risk associated with serious adverse effects. So some of these serious adverse effects can be significant weight gain, diabetes, high cholesterol, which obviously gives you a much greater cardiovascular risk associated with it. Okay, speaking of adverse effects, we'll start having a look at a few common ones associated with both first generation and second generation one. So the extraprimordial side effects are more evident when you're dealing with the typical antipsychotropics, but still can happen with the atypical or the second generation. Now, because they work on blocking the dopamine receptors, they also have a secondary effect on the dopamine 1 receptors in the brain, and it's that particular receptor that is associated with the extraprimordial disturbances. So common ones is obviously you get your Parkinson's disorders or your pseudo-Parkinsonisms, acute dystonias. You can also get akathisia and tardive dyskinesia. Now, as mentioned, they're far more common with the typical as opposed to the atypical, because atypical has pretty much little to no effect on the dopamine 1 receptors. Now, the classic signs and symptoms of these particular ones is when you have your pseudo-Parkinsonisms, you end up with tremors, inability to walk properly, you end up shuffling along, and you have this disorder where you constantly it looks like you're rolling something like dough in between your fingers. Now, acute dystonias we're pretty familiar with, but it's not just the ocular gyro crisis that occurs. The most common ones is your grimacing and muscle spasms of the tongue and face and all that sort of stuff. Akathisia is best described as the inability to sit still, so it's profound restlessness. So if you're someone sitting down and they suffer from it, they're constantly moving, their feet are constantly in motion, and it's very debilitating. Now, tardive dyskinesia is probably the most serious condition that affects muscle coordination. It's characterized by repetitive, involuntary, slow movements, often your lip smacking, your tongue movement, so it makes it very difficult to communicate or eat pretty much anything at all. Usually, when you're taking medication, you won't see tardive dyskinesia until they're on it for a long period of time, about 1 to 2 years. By that way, the neurotransmitters in the brain, most of the receptors, will actually change, and you'll end up having these effects, can be forever. So you can get tardive dyskinesia for the rest of your life, even if you stop the medication, which is a horrible thing to live with, and unfortunately is heavily associated with completed suicide as a result of these adverse effects. So certain medication that have these particular side effects is your Ligactyl and the haloperidol can be quite commonly associated with these extraprimordial effects. Now, on top of these extraprimordial effects, we can also get different adverse effects. A lot of the ones are associated with sedation. So sometimes it's a good thing because restlessness can be a problem, but it can also play a huge havoc on people's lives, especially if they have to drive, do activities, that sort of thing. The cardiovascular risk we already mentioned, associated with the atypical ones, often results in the second generation not being as used as much. So you can end up with things like orthostatic hypertension, dizziness, a prolonged QT can be associated with it, and also the development of diabetes. And because it blocks the histamine receptors, you can put the person in significant weight gain and the associated hypertension as well. Different side effects can do with the cholinergic side of the house, so people end up with dry mouth, blurred vision, urinary retention, constipation from the blocking of the muscarinic receptors. And there is a particular disorder associated with chlorhexidine, which is associated with the development of a blood disorder called agranulocytosis, which is a fatal blood disorder that grossly lowers your blood cell count. Unfortunately, it can occur in 1 to 2% of patients who are taking chlorhexidine. So it's definitely one to look out for, and is often associated with regular blood tests as well. If they do get it, then obviously the antipsychotic medication is stopped, so the condition can be reversed over time. So when they're on these particular medications, they need to have observation and regular monitoring of these cardiovascular risks and blood disorders, and education about the symptoms is vitally important. You really need to write it down for the patient, because the patient often requires a carer, which we'll look at a little bit further. So when you're dealing with a patient who's on these medications, if we're suffering from things like schizophrenia, our clinical decision-making process needs to be focused on the patient's well-being and the patient's compliance. So compliance in taking their medication. So as you're doing the assessment, you need to make sure that the patient and their family or carer has a realistic knowledge of the illness, okay, and has a realistic understanding of some of the side effects associated with the medication. Need to be upfront in other medications given, because a lot of them will have interaction and adverse effects, and you need to be fully realistic at the person's ability and reliability for self-care. Obviously, if you look at the disorder of schizophrenia, it's met with hallucinations and delusions. So a lot of patients will convince themselves very easily that they don't require the medication, and they'll cohort and they'll hide and they'll say that they've taken it, say that they're compliant, because in their mind they believe they don't need it and that everybody's out to get them. It's quite common that schizophrenia is associated with massive non-compliance for medication, particularly oral medication, to the point that they've actually started depot formalization of the medication, so then the patients can just get an injection every 2 to 4 weeks and therefore increase the adherence overall. Obviously, the goal at the end of all this management is the person understands the illness and medication, and they don't have any of the big adverse effects. Same true that whilst they're on the medication, they remain free from injury and free from all the adverse effects, and that they maintain their compliance with the medication regime. When giving the medication, you need to illustrate the importance of monitoring the administration, obviously due to the risk of non-compliance that we spoke about. You need to have a look for the adverse effects, especially the cardiovascular risks and the extrapyramidal movements. If it requires blood tests, then you need to make sure those blood tests are actually conducted regularly. You need to monitor the person's weight every couple of weeks, as it's a relatively common side effect, and provide profound information, including long-term management and advice against stopping the medications abruptly, because the withdrawals can be quite severe, and provide the person with support networks, phone numbers, case managers, crisis hotlines, things like that. Okay, let's move on, and we'll have a look at a different disorder now, and we'll have a look at our anxiety. Now, I'm going to not give anxiety a lot of credit, not because I don't believe it exists, but when you read the DSM-5, so the Diagnostics of Standard Manual of Mental Disorders, there's an entire chapter on anxiety disorders, and it includes a huge spectrum associated with generalized anxiety disorders, all your phobias, and what makes it even more difficult is anxiety itself is a condition, but it's also a symptom of other conditions. Now, the exact pathophysiology of anxiety disorders is not fully understood, but they know that it's associated with the amygdala area of the brain. Now, the amygdala is associated with your fight or flight response. So it triggers when you're scared or when you're threatened, and when you need a profound response associated with your environment. Now, people that suffer from anxiety can start to see that everyday normal events can trigger this same response. Okay, so they're extremely overactive, and they have a huge sympathetic drive. They have a problem with their emotional memory, in the management of emotional memory, controlling fears and controlling their anger as well. Okay, so it's particularly debilitating, and obviously there's an entire spectrum of anxiety-based disorders. Now, a lot of the time the medication associated with anxiety disorders is your antidepressants. So they'll be put on your antidepressants, like your selective serotonin reuptake inhibitors or noradrenaline reuptake inhibitors themselves. But quite often, the main management associated with anxiety is your benzodiazepines. So benzodiazepines are used for your anxiety disorders, but it's also used for seizures, as you know, and alcohol withdrawal. So the most common one out there is probably Valium, and it's used for your anxiety, and you can also have diazepam, which is quite useful, especially as a sleeping tablet. Okay, so these drugs can be given long term, but they're definitely given short term in acute cases of anxiety as well. Now, there's another one out there that is used to treat anxiety that is not a antidepressant, and it's also not a benzo, but it's Zyban, which is a buspirone. So it's used in there. It's often confused with a benzo, but it's definitely not a benzo itself. It's used these days to treat anxiety and depressive disorders when the other ones don't work or have adverse side effects that cannot be tolerated. Okay, so it's a second line option of what can be used. Now, when we look at benzodiazepines themselves, benzos are classically rapidly absorbed within the GI tract. Now, obviously, we're talking the tablet version in this case. They're highly liposoluble, which means they have the ability to cross the blood-brain barrier, obviously. But they can also go past the placenta and into the baby and be transferred via breast milk as well. Now, benzos are classically protein-bound medication. Okay, so they can be 98% of all the benzo, like diazepam, that is protein-bound. So when they go through the system, they undergo extensive metabolic changes in their metabolism through the liver. Okay, so the response for the administration of benzodiazepine is often quite long. Okay, so it has a very long half-life and a long-lasting metabolism as well. Now, it's excreted by the kidneys, which needs to be taken into account because of its already existing long half-life associated with the protein bound and the need to go through several stages of metabolism to make the metabolites. If you have a problem with excretion, then you get extensive effects, and it can be up to 100 hours of effects with the benzodiazepines. Okay, so just to be careful. When we're looking at its action, it reacts as a booster to the GABA itself. Okay, so GABA is our gamma aminobutyric acid, and it's a neurotransmitter within the brain that has an inhibitory effect on the neurotransmitters. So when GABA comes along and binds with the postsynaptic neuron, it encourages the uptake of chloride. Now, chloride is obviously an anion, so it lowers the membrane potential of the associated neuron. Now, when you get a benzodiazepine, it will actually bind to the bed of the postsynaptic neuron, and it acts as a booster for this GABA receptor. Now, by booster, what I mean is it has more of a profound response of absorbing the chloride, therefore lowering the potential and stopping the actual transfer of the action potential. Okay, so that's why benzodiazepines are very useful in seizures, okay, because it stops the passing on of the actual potential, so it stops the actual message getting through. And it's also very good in the management of anxiety, because remember, anxiety is associated with overstimulation of certain areas of the brain, bringing on this fear or over anxious response. Okay, so that's why benzodiazepines work quite well when dealing with conditions like your anxiety and alcohol withdrawal and that sort of thing. Now, when people are on it, they need to have certain risks monitored. So because of its sedative effect, there's a huge falls risk. Because of its long half-life and effects on the kidneys and the liver, you need to monitor the effectiveness of both of those in order to make sure that there's not a profound effect or a magnified effect of your actual benzodiazepines. People that come off benzodiazepines suddenly can go through quite a nasty withdrawal from there. And also, let's not forget that most benzos, whilst they are S4s, they are treated as S8s because of its associated drug of addiction and risk of abuse, to the extent that a benzo called alprazolam has actually been upgraded to an S8. in the last 3 or so years, it's gone from being an S4 to an S8, having the same control because of its abuse. Okay, moving on from anxiety, let's have a look at depression. Now, depression is another one of those disorders that is misunderstood. It's often just cheaply given as someone feeling sad or someone feeling upset, but it's that on steroids. It is associated with profound sadness, lethargy, loss of appetite, insomnia, personal neglect, and huge association with suicidal tendencies. Okay, so depression has been linked to having reduced levels in the brain of both NORAD and serotonin. So NORAD and serotonin are associated with feelings of happiness, same too as oxytocin, but by having reduced levels in the brain, I believe that people will actually have this depressive state and this feeling of worthlessness pretty much all the time. So when we start looking at medications, we obviously are looking at our antidepressants. Now, antidepressant pharmacology has come a long way in the last 10 to 15 years, and the idea of them is obviously, instead of working like the other two that we've spoken about, which is stopping certain potentials and working as an inhibitory, this one here is associated with increasing the levels of serotonin and noradrenaline. Now, a lot of them out there are very selective, and then a few of them are less selective. And the easiest way to think of it is the least amount of selectiveness you have in an antidepressant, the more adverse effects you're going to have. The more selective they are, as in more fine-tuned they are at working on certain receptors, the less adverse effects you're going to get. So we're going to have a look at a huge class altogether, okay, because they work a pretty similar way. So we have SSRIs, NRIs, and SNRIs. So they stand for selective serotonin reuptake inhibitors, and then we have NORAD reuptake inhibitors, which unfortunately are also called SNRIs, as in selective NORAD reuptake inhibitors. And then you have serotonin and NORAD reuptake inhibitors, which is what the picture in front of you is showing. Okay, one that will actually block both receptors. So every neurotransmitter that comes from a presynaptic cleft into the actual synaptic cleft and then hits the postsynaptic membrane. After it triggers a response and passes on a message in the postsynaptic membrane, it is picked up and taken away and then brought back to the original receptor most of the time, or it is destroyed. So in the event that it cannot be destroyed, or it cannot be reuptaked into the presynaptic region, it is going to stay in the synaptic cleft and therefore have more of a pronounced response or a repeated stimulation of the postsynaptic membrane. Okay, so that's what these particular drugs are trying to take advantage of. You have a pathological state that has a reduced level of these neurotransmitters, so by taking these particular medications you are trying to prolong the presence of these neurotransmitters in the actual synaptic cleft. So classic examples of SSRIs is your fluoxetine and fluvoxetine and sertraline, and an example of a NORAD reuptake inhibitor is reboxetine. Now, the main risk associated with using SSRIs or SNRIs is the associated serotonin syndrome. Now, serotonin syndrome has similar effects that you'll get from your cholinergic, okay? Because it's essentially what's happening with cholinergic toxicity is the inability to get rid of the neurotransmitter acetylcholine, and therefore you're getting repeated stimulus. So serotonin syndrome is associated with hypothermia, tachycardia, and really high blood pressure. the persons can get diaphoresis, shaking, the feelings of anxiety, agitation, diarrhea, and confusion. Okay, so it's quite a nasty adverse effect, unfortunately. Now, when we look at one that works on both serotonin and noradrenaline reuptake inhibitor, it obviously blocks both of them. Okay, and an example of those is your duloxetine. So duloxetine will actually be a serotonin NORAD reuptake inhibitor. As far as TCAs go, looking at the picture on the right, a TCA is a different type of antidepressant, and it's not as selective as your SSRIs or your NRIs. Okay, so tricyclic antidepressants will actually block the amylin reuptake pump. Okay, so by blocking the amylin reuptake pump, it actually encourages NORAD and serotonin to remain in the synaptic cleft. Okay, so it works similar, so it has these similar effects as your SNRIs, but it also has associated other effects, unfortunately. So an example of the medication that most people know is your amitriptyline. Now, the reason your serotonin NORAD reuptake inhibitor was invented was because of the associated side effects to do with your TCA. So TCAs will they'll block the reuptake of serotonin and NORAD. Okay, that's the positive effects. It's the same as the SNRI, but you also have associated effects with blocking the muscarinic receptors, therefore not allowing acetylcholine to pass over, and you also can block your histamine receptors as well. So the side effects is dry mouth, blurred vision, constipation, urinary symptoms. You can also get your orthostatic hypertension, weight gain, sedation, and cardiac arrhythmias when dealing with toxicity. Okay, so tricyclic antidepressant toxicity is a medical emergency, okay, and it needs to be picked up because it has both cholinergic and histamine effects. It also has the associated risks that used to be found in a very old class of drugs that we'll look at next. Your MAOIs, okay, and your RIMers as well. So these are very old type of drugs, and they're not commonly used anymore unless, of course, you have poor management or poor response to the other types of antidepressants. Okay, so MAOIs stands for your monoamine oxidase inhibitors. Okay, so monoamine oxidase is an enzyme that metabolizes serotonin, NORAD, and dopamine. The neurotransmitters obviously that are most associated with your depressive states. Therefore, by inhibiting the monoamine oxidase, it makes more of these neurotransmitters available in the synaptic cleft. Okay, so by blocking the ability to transfer these neurotransmitters, we have an increased effect within the postsynaptic neuron. Okay, so we have two different types. We have MAOA, which is your serotonin, NORAD, and dopamine, but then you have MOA enzyme B, which is associated with dopamine and thiolamine as well. Now, thiolamine is a substance that is produced within the neuron that will encourage hypertension. So it encourages vasoconstriction. That's what it does. So when you have certain foods that commonly will actually hold these particular substances, thiolamine, the classic ones is your chocolate and your cheese and that sort of thing, you release this particular neurotransmitter, thiolamine, but the body has the ability of picking it up before it actually reacts with the postsynaptic neuron, and therefore it has no effect. But when you're on your MAOIs, you lose that ability. So that's why it has a massive interaction with food and a massive interaction with a lot of other drugs. Okay, so MAOIs have a huge list of interaction with pretty much all drugs that work even remotely close to neurotransmitters, and a lot of foods as well, a lot of foods that people like to eat, which is why they invented urimers. Now, urimers are also called reversible monoamine oxidase inhibitors. Okay, yeah, I get it. I don't get it either. Okay, they shouldn't be called that, but that's what they're called, and they're referred to as RIMers. Haven't really been able to find out the reason why. But anyway, to the point, they inhibit your MAOA enzyme only. So they'll only have an effect on your serotonin and your NORAD mostly. They will not have the associated effect with your thalamine production or your thalamine inhibitory. So breaking down the thalamine, therefore they have less side effects. Now, the examples of drugs that you'll find in these ones, so your MAOI is your phenylthiazine, whereas your RIMer is your moclopramide, probably the most common one, and it's more selective. So because it's more selective, it has less adverse effects. Now, both these type of drugs, particularly MAOIs, like I mentioned, are only used in pretty extreme circumstances, and when patients are on it, they need to be fully educated on a huge list of adverse effects, and in particular, interaction. Other things to consider when dealing with the use of antidepressants is the therapy may take 3 to 4 weeks or even up to 6 weeks before they can kick in. And antidepressants that cause sedation should obviously be taken in the evening. Now, your frontline treatment for depression is your SSRIs and your SNRIs. And as mentioned, second line are more of the less selective ones, tricyclic antidepressants, MAOIs, or even RIMers. Now, adverse effects often will influence the medication compliance. If people get adverse effects, then they're less likely to take it. There is a phenomenon, unfortunately, especially with SSRIs, that has associated rebound effect of increase in suicidal ideation. It basically works on the pretense that they're so depressed that they can't be bothered going through suicide or completing suicide. So if they're given a little bit of drive through the SSRIs in the initial sense before their management is under control, then they can have the drive to complete suicide. It's not very fair if you ask me, but that's things that they have found. Now, another problem with antidepressants is that they've never been tested on children, so we don't even know if they work, and they also have very serious considerations need to be taken when given with pregnancy or even post-pregnancy, because the lack of studies we have on the effects of antidepressants with children. Now, overdose is the most serious type of poisoning when you're dealing with antidepressants. Now, like I mentioned, suicidal risks associated with antidepressants means that people can often take huge dosages of the medication and get mixed with things like serotonin toxicity, and then also your tricyclic antidepressant toxicity as well. As far as monitoring goes, you need to be very, very careful with drug interactions, kidney and liver function again, as well as just want to harp on a bit more about the associated suicide risks. The education must be there. Okay, the last disorder we'll look at just quickly is your bipolar disorders. Now, bipolar disorder is simply explained as episodes of depression and mania. Now, a lot of people incorrectly think that when a person's in mania, then they're on a high, and that's where we want to keep them. We want to keep them in this manic state, okay? But it's not the case. It's not a matter of being happy then sad. It's a matter of being completely erratic and almost uncontrollable. You have no inner filter, if you will. You have no inner voice that tells you that certain things are bad or risky behavior or have adverse effects. Okay, so mania is often associated with huge, grandiose opinions of yourself and often very erratic based behavior. Whereas your depression, we're talking very, very low depression. Okay, so it's like what we spoke about before, where they'll go through very varying stages of self-doubts and worthlessness, mixed with this grandiose feeling that everything's going to be amazing regardless of what they do. Okay, so as far as how quickly it changes, it depends on the disorder, and as with all these disorders, there's huge overlapping considerations with each, and as I mentioned before, that's the crude definition of bipolar. And you can have mixes with more mania, less depression, more depression, less mania, and that sort of thing. Okay, there's never a simple diagnosis whenever you're dealing with any mental health disorder, in particular bipolar. Now, the management of bipolar, when we're talking from a pharmacological sense, is we want to have it effective for treatment of mania and bipolar depression, and also effective at preventing mania and bipolar depression. So you want to be able to do both. Okay, now there's a few drugs that are used in the management of bipolar. We have our lithium, and you have your sodium valproate, and then you can also have your second generation antipsychotic medications, which is mostly used in your acute manic or relapse stage. Okay, and then you can also chuck in there antidepressants that are used during the depressive episodes. Okay, so it can get quite bloody confusing, for lack of a better term. So the two drugs that we'll look at in particular will be our lithium and our sodium valproate, because we've already talked about second generation antipsychotropics and your antidepressants. So when we look at lithium itself, we don't actually know the exact mechanism of what lithium does. Okay, and I've looked lots of places, and what I've found is it has a very, very close link to sodium within the cell, so intracellular sodium. Now, patients that suffer from mania, it has been reported to have a huge amount of sodium, up to double the amount of sodium found within the cell. Now, lithium and sodium both are actively transported through the sodium channels. Okay, but lithium can't be pumped out, so it's not actually associated with the lithium potassium pump, so it sits in there. And by sitting in the cell, it slows down the effectiveness of sodium, thereby inhibiting or slowing down a lot of processes. So generally speaking, it inhibits the transmitter's release at the synapse, especially dopamine, and in turn increases the turnover, so the reuptake of NORAD and serotonin. Okay, now what makes it even more confusing is if somebody suffers from mania alone, so just has mania and not the bipolar switch, then lithium has little to no effect at all on mania. But lithium has the most extensive evidence for prophylactic benefits for preventing mania itself. Okay, so it makes it very and frustratingly confusing. Okay, now on top of that, lithium itself can be very, very dangerous. Okay, but it is still the drug of choice as a mood stabilizer, especially for presenting those acute manic episodes. Now, there is even studies out there that suggest that lithium has the ability to protect against neural apathy and neural breakdown, okay, which is another theory of what causes the bipolar disorder is actually neural degeneration. So lithium prevents apathy and actually can promote neural growth. Okay, and it also has suggested distribution of calcium, sodium, magnesium as well, so it can control or alter the distribution of these cations, okay, which is obviously critical for neural function. Now, the effects of lithium are not evident until about a week. Okay, so therefore, in acute stages where you're initially starting out, people will often need some sort of different management, or antipsychotropics like your olanzapine second generation can be used in the acute stage until lithium can actually kick in. Lithium itself, as I mentioned, is quite toxic, so it's metabolized by the liver and excreted by the kidney. Another problem is it has a very, very narrow window associated with its therapeutic range, and if you go too far above or too far below, then you won't actually get the effects and you'll have a relapse, or you'll increase the risk of acute toxicity. Okay, so it's very dangerous. Now, when someone starts off on lithium, they need blood testing. They need weekly, then monthly blood testing, and unfortunately, it can be closely associated with the development of comorbid diseases like cardiovascular and respiratory problems. Okay, because of its close link to sodium, people need to be acutely aware of the importance of hydration as well, and not to take increased sodium that you wouldn't naturally get within your food. Okay, so sodium levels are something that also need to be monitored as well. Now, there's also massive interaction with very common drugs. So your NSAIDs, they actually will increase the level of lithium that is found in the blood. So if you're taking non-steroidal anti-inflammatories with lithium, you increase the risk of toxicity. You also have to be careful not to take diuretic, in particular the sodium excreting kind, okay, because you need the sodium within the body. And things like taking diuretics, coffee, alcohol, that sort of thing is also something that you need to be careful of. Now, the worst thing associated with lithium is when you're on lithium a long time, you can get chronic lithium toxicity. Okay, you can build it up within the cells, and then basically you can end up with chronic type symptoms, unfortunately. Now, when we're dealing with toxicity, if you have a small level increase, then you get your nausea, vomiting, diarrhea, muscle weakness, drowsiness. So getting those symptoms, it could be lithium, the start of lithium toxicity, so they need to be monitored. So every time you unfortunately have nausea, vomiting and diarrhea and weakness, you should get your lithium levels checked. Now, if it gets significantly high, that's when your arrhythmias, dysrhythmias, hypertension and seizures come into play. Okay, so I think I've prattled on enough about lithium. There's just a lot of considerations to put in play when dealing with that drug. Now, sodium verapamil, it is also metabolized by the liver and the kidney. Now, this also has pretty significant adverse effects. So it has the same nausea, vomiting, dizziness, headaches, but then you can also get somnolence and tremors. You can even get sedation, liver damage, so you end up with raised liver enzymes, and you can get a huge amount of hematological effects like thrombocytopenia as well, so you can have bleeding problems. Okay, so the drugs associated with the management of your bipolar need to come with a huge amount of education and obviously monitoring. Okay, let's have a closer look at our clinical considerations that we need. So whenever you're starting on these particular drugs, now these are the ones associated with anxiety and depression, or a mixture of both, your assessment needs to include baseline vital signs, weight management, blood pressure, pulse rate, okay, in particular the ones associated with the medication. So tricyclic antidepressants causing tachycardia, MAOIs causing hypertensive crisis, and also selective serotonin having that starting point of serotonin syndrome. You need to monitor the actual behaviour of the treatment itself. Have a look at sleeping patterns, eating, energy levels, interaction with others, support groups, that sort of thing. Always ask about suicidal ideation, regardless of how long they've been on this management. Okay. Now, the goal of the management is to remain free from injury. Okay, always self-harm. Okay, is very important to monitor, but also adverse effects. You need to make sure that the people on these medications have the required family and support networks, and if they don't, then give them external agency support. When they're on medication, they need to take it regularly, and it's very important to take it at the intervals prescribed. Regards to implementation and evaluation, when they're starting off on the medication, you need to monitor for adverse side effects and educate the hell out of the patient. Give people all the associated risks of that particular medication, as well as the short-term, long-term risk and make sure them, their family members, and their actual carers know. As with all cases, especially when you're dealing with antidepressants or medications that cause extreme adverse effects, make sure they have that support network. Okay? Make sure that your ongoing management is in place for reducing or stopping suicidal ideations. People with mental health disorders taking medication that have pretty nasty adverse effects, it is a constant battle for them to remain compliant with the treatment. They know that if they take the medication, they're going to get some adverse effects. If they don't take the medication, they're going to end up back within the condition. So it's a constant back and forth with the person. So you need to evaluate and support the importance of remaining compliant with the treatment regime. Okay, so that ends pharmacology of mental health. I understand it's quite a long episode, but there's a lot to go through. It's not an easy journey for people suffering from mental health disorders, and pharmacology is one of the managements associated with its care, but one that, as you can see, is often associated with some pretty extreme adverse effects and life-altering side effects. Okay, so the main management for people suffering from mental health conditions is that support network. Okay, and having someone to talk to, having someone to retrain the brain. So none of these medication should be taken alone and should be taken as a complement to cognitive behaviour therapy, to support networks, and to retraining neural pathways. Until next time, take care.